patient is a 34-year-old gentleman. He is a case of tetralogy of Fallot with pulmonary atresia with a duct-dependent circulation. He underwent initial two-stage surgical repair from Great Ormond Street Hospital. Okay. The first surgery was a pericardial patch enlargement of the right ventricular outflow tract at 9 months, which was followed by complete surgical repair at 22 months, where the VSD was patch closed, the infundibulum was dissected, there was a transalveolar patch plasty of the RVOT, and the LPA, which was hypoplastic, was augmented using a bovine pericardial patch. He was doing well and he is having class 2 symptoms for last 3 years. His echocardiogram showed progressive right ventricular dilatation and pulmonary regurgitation. So we performed a cardiac MRI. There was significant elevation in right ventricular end-diastolic volumes, which was 199 ml. It's almost 22 ml increase in the last 1 year, and the RVEF was reduced to 46%, which was 50% 1 year ago. The right ventricle to left ventricular volume ratio was 2:1, and there was a pulmonary regurgitant fraction of 30%. There was severe LPA origin narrowing with the right to left perfusion of almost 6:1. This is the chest X-ray, which shows mild kyphoscoliosis. There is a cardiomegaly with a CTR of around 65%, and the RPA segment is dilated, whereas the MPA and LPA segments are not very prominent. This is an ECG which shows right bundle branch block. This is the echocardiography. Here we can see that the right ventricle is quite significantly dilated compared to the left ventricle, and this is the RVOT. The images are not very good, so I will show the CT images in subsequent slides. This is the CT reconstructed image. This is a multiplanar imaging. Here we can see this is the RV, the dilated RV, the RVOT, which is almost pyramidal, and this is the LPA origin, which is quite significantly narrowed, and this is the hilar LPA. So this is the reconstructed image. Here we can see this is the dilated and trabeculated right ventricle. This is the right ventricular outflow tract, and I am slicing towards the LPA. This is in the lateral view or in the sagittal view. This is the RVOT. This is the LPA origin, which is narrowed, and this is the hilar LPA. Now I will show this is the RPA origin. Now I will slice again from cranial aspect. Now when I am slicing, you are seeing the aorta, then you will see the right ventricular outflow tract, the RPA origin, the RPA, and this is the narrowed LPA origin. When I slice further, we can see the LPA is roomy in the distal part.
As well, we need to relieve the left pulmonary artery narrowing and bring about an equal perfusion to the right and the left lung. Yeah.
I will just show a virtual stenting here. So as sir explained, we are doing a stenting from RVOT towards the LPA. So this is the virtual stenting. Here we can see the LPA, the RPA origin will be flowing through the struts. So we will prefer to use a stent which has open cells here. Again, in the cranial slice, we can see here, this is the stent from RVOT to the LPA, and this will be the flow to the RPA through the struts. So we will be using a open cell design.
The right atrial mean pressure was 12 millimeters of mercury, indicating elevated RA pressures. The right ventricular systolic pressure was 60 millimeters of mercury. The right pulmonary artery pressure was 35 millimeters of mercury, indicating that there is a 25 gradient across the distal main pulmonary artery, which Dr. Pramod showed that it was narrowed. The left pulmonary artery was severely narrowed. We can appreciate that the right ventricular outflow tract is sort of pyramidal. There are calcifications in the region of VSD patch. There are also calcification in the region of proximal right ventricular outflow tract, which was originally reconstructed with a polytetrafluoroethylene membrane or Gore-Tex membrane. The RVOT is pyramidal. The distal RVOT or the distal pulmonary trunk seems narrow. The right pulmonary artery is quite roomy. The left pulmonary artery is severely narrowed. Here again we are seeing that the distal pulmonary trunk is narrowed minimally. The left pulmonary artery origin is extremely tight, and the hilar left pulmonary artery was good in size. In the right pulmonary artery was measuring around 25 millimeter. The distal pulmonary trunk was 20. The proximal main pulmonary artery was around 27, quite roomy. Left pulmonary artery origin is very small at 4 millimeter, but the hilar part of left pulmonary artery was more than 17. So we did a small pre-dilatation of the left pulmonary artery. This is a pre-dilatation that was done with a 10 millimeter Mustang balloon made by the Boston Scientific. The vessel fully yielded at 10 atmospheres and we went up to 12 atmospheres. So this is after the dilatation, we made another check just to see what is the left pulmonary artery. And here we find that it is still narrowed. So indicating that there is a substantial recoil of the left pulmonary artery despite the balloon dilatation that we gave. So this is a 49 millimeter long Zephyr stent mounted on a 20 into 5 ZMed balloon and protected by a small 14 French sleeve, and it is going through a 14 French devil sheath, which is a long braided sheath that has already been parked in the left pulmonary artery. I'm advancing the stent to the desired target. So the target was partially across the left pulmonary artery and partially across the main pulmonary artery. So I'm going to peel back the sheath in order to expose the stent. So I'm withdrawing the sheath. So we are positioned about 40% in the left pulmonary artery, about 60% in the main pulmonary artery. So the stent is now straddling the tight stenosis of the left pulmonary artery. Can you come and take over the inflation? Left pulmonary artery and the distal main pulmonary artery stenosis is also. So at this point, I'm withdrawing the pigtail a little bit more inside. Yeah, we can go ahead. Just push the contrast. Yeah, keep on enlarging. Okay, go to, what is the burst pressure? 5. So go up to 5 atmospheres. 5. And deflate. We'll wait for the systemic pressures to bounce back again. It's coming back. Let me try to advance the pigtail a little inside the outflow tract. Okay, let's give one angiogram here. Okay, now let's do some post dilatation in order to ensure that the stent is fully opened out. So now we are taking in a 20 millimeter Atlas gold. So now I am exposing the, go up, Dr. Pramod.
I'm going slowly. 1 atmosphere now.
Okay, I will give some initial inflation so that it is easy for you to take it further. Yeah, what is the pressure now?
It's 1.
Yeah,
I'm going to 2, 3,
okay.
4,
That's enough.
5,
That's enough.
4.
So now I am deflating. I am deflating the balloon, hoping that the pressure comes back. Actually, we are occluding the entire right ventricular outflow tract during each of our inflation, so the blood pressure drops down significantly. Now I'm going to slightly pull back the balloon so that we make a proximal dilatation as well. So at this place, can you go up?
Yes. I'm inflating. to 2, 3,
That will be enough.
4.
Yeah, the proximal part of the stent is not opposed to the wall. So we will expand it so that the proximal portion is well opposed. Shall we do that with a reliant balloon? Yeah, reliant balloon is basically a compliant balloon that can be used. So here, this was actually showing the distal main pulmonary artery trunk narrowing very clearly. Here it looks reasonably opposed. Show the previous view. The previous view was not showing a good opposition. Yeah, so probably on the leftward side of the outflow tract, we have not got a good opposition, which will push the stent towards the walls of the outflow tract. So I'm taking in a reliant balloon. So I'm now peeling back the sheath and I'm going to give an expansion. This is a soft balloon and it expands quite substantially and flares the wall of the stent to the entire outflow tract. I'll do that a little bit more proximally also. I'll take out this balloon and put in the marker pigtail now. Okay, ready for 25 ml at 18 rate? So the right pulmonary artery is filling from the side struts. The main pulmonary artery now has got a stent that is well opposed to all the walls. Now we will go for another injection. So now we are shooting another picture in an orthogonal projection. Yeah, the stent is reasonably well opposed. Now what we'll do is change the devil sheath into a python sheath. Python sheath is the sheath for introducing the valve through the groin. It's an expandable sheath. Now I'm going to take out the devil sheath. And now we are taking this python sheath, the groin. So it goes in rather smoothly. So now I am taking out the dilator. So here, let us take the measurement. Probably that will give us a good idea about what is the valve size. By eyeballing, I probably felt that it may be around 24, lower to lower, correct. So now we are doing the calibration. Yeah. Okay, a little below that. Little below. Another line little below. Yeah. So this is around 22 millimeters now. Can you measure the length of the outflow tract below the bifurcation? So it's around 24. So now I am going closer to the outflow tract. So this, at this part, the advancing the balloon will need a pull and push So I'm getting the wire deeper. I'm reducing the guide wire bias. I am making a loop in the right atrium in order to push the assembly. Okay. Okay. Now I will try to loosen the loop in the right atrium. The distal end of the Myval is now overlying the origin of the right pulmonary artery. We are ready for the inflation. The initial inflation will be slow, and then as we go deeper, then it will be faster. Now start inflating, start inflating, keep inflating, keep inflating, keep inflating, keep inflating, keep inflating. Go full, fix the valve. Enough. Okay, deflate. So this is the right ventricular outflow tract angiogram. Now we need to carefully take out the navigator system. The balloon has come out now at this point. The blood pressures are stable. I'm taking the marker pigtail.
Go to 100 scales.
So show both the pressures in 40, 50 scales. Yeah. Take the mean out of the right ventricle. There are a few ectopics. He's slightly venky backing.
He was having a trifascicular block before the procedure, and
Okay.
intermittently during the procedure he was having episodes of venky back.
Okay.
But it was not causing any hemodynamic significance as such. We are observing it.
Okay. Yeah. It shows that there is no pulmonary regurgitation. Yeah, it looks fine. The follow-up now, what we'll do is, since there are large vascular access that has been taken, we would like to give low molecular weight heparin, enoxaparin, 60 milligram 2 times a day for the next 48 hours. Being a percutaneous pulmonary valve, we will continue the IV antibiotics for another 3 more doses, and then switch over the patient from today evening to aspirin plus Plavix in antiplatelet doses. So we will be giving aspirin at a dose of about 150 milligram and Plavix at a dose of around 75 milligram, clopidogrel at 75 milligram. Thank you. Goodbye from Madras Medical Mission Hospital.